Good morning, good morning, or good evening, or good afternoon, depending on which part of the world you are based. Together with my co-chair, Dr. Duseiko from London, UK, we're chairing this, I think, very interesting session on the clinical management of thalassemia based on the TIF guideline recommendations. And it is important because this session is important because, as you very well know, TIF has very recently published a new edition of the guidelines for transfusion-dependent thalassemia. So it will be interesting to see how these guidelines are implicated in clinical practice. And for this, we have 5 excellent speakers from different parts of the world. And without any further delay, we will start with the first speaker, but please remember that we need your interaction, we need your questions, so please post your questions in the provided Q&A function, and also address a specific speaker, write the name of the speaker to whom you want to pose the question, and we will address the questions at the end of the session. So the first speaker is Dr. Farouk Shah. She's a consultant hematologist at Whittington Hospital in London, UK, and there will be a presentation on blood transfusions.
Hello, it's my great honor to be speaking at the Thalassaemia International Federation conference, and I'm delighted to present on transfusion in thalassemia syndromes as per the Thalassaemia International Federation guidelines. So what is the goal of transfusion therapy? Well, the primary goal of this is obviously to prevent chronic hypoxemia. It's to reduce the compensatory marrow hyperplasia and to promote normal physical activity. It also is really important in preventing secondary bone changes, in particular thalassaemic facies, and also prevents the early development of splenomegaly and hypersplenism. And of course, it reduces gastrointestinal iron absorption in the patient population. The biggest challenge around transfusion is knowing when to differentiate between transfusion-dependent thalassemia and non-transfusion-dependent thalassemia. The TDT population generally present with severe anemia before the age of 2. They may or may not need transfusion at that point, but they will be presenting with severe anemia. The hemoglobin can be between 6 and 7 grams per deciliter, and they have a high hemoglobin F with a low hemoglobin A2. Splenomegaly at presentation, particularly if presentation is a little bit late, can be significant, and there is a lifelong dependence on transfusion. In the non-transfusion dependent cohort, they frequently can present with mild to severe anemia, but generally this is above the age of 2. And hemoglobin F may be anywhere in the range of between 10 and 50%, and in some cases up to 100%. But they also have a raised hemoglobin A2, and they may present with mild to severe splenomegaly at presentation, particularly if the presentation is late. They don't necessarily need transfusions to maintain survival, but they may be on either occasional or frequent transfusions, depending on what's happening with them clinically. And the primary route of iron absorption in the non-transfusion dependent patients is, of course, through gastrointestinal iron absorption. So when should you be thinking about transfusion? Well, we know that blood transfusion can have a very significant impact in patients. And this is a classical picture from Nature reviews on thalassemia patients with hemoglobin E beta thalassemia. And you can see the significant variability in the clinical phenotype in this population of patients. What we do know from significant data collected through a variety of different groups is that patients who are non-transfusion dependent have poorer performance scores than patients who are transfusion dependent. And what you can see here is that all the patients who are beta thalassemia, as represented by the blue color, have got a significant reduction in physical functioning, an increase in body pain, and they tend to have poorer health generally overall. This is a new baby with beta thalassemia major, and this is where the importance of monitoring becomes very important. So this is a new baby. Baby is growing well and doing okay up until about the age of 3 months. And then what you can see is that there is a flattening of the baby's growth curve and their weight, and they become very clearly visibly on this graph as having evidence of failure to thrive. And then obviously once the child starts transfusions, they will improve significantly. What we know is that when you start transfusions, particularly in the non-transfusion dependent patients, you will see a very significant improvement in their general performance score, but also in their height, velocity, and they're more likely to achieve a better final height. This is a non-transfusion dependent patient who was failing to transition into puberty. And what you can see here is at the age of 13 and 12, extremely low growth charts. And then when we initiate blood transfusions, you see a rapid improvement, bringing the child back into the height that they should be expecting to achieve with mid-parental height. And in addition, this particular young patient achieved puberty successfully. So the question here is, why is the decision to transfuse so complicated? You'd have thought it would be easy and simple for us to do. The reason is mainly because different doctors have different thresholds for starting transfusion, and because different patients have different thresholds for wanting or accepting transfusions, and because the availability, cost, and the safety of blood are not the same in all countries, and it is a balance of risks between the risk of infection and the benefits gained from transfusion. And the other decision that makes it very difficult, certainly in the non-transfusion dependent cohort of patients, is because of people like this. This is a 54-year-old female with compound heterozygosity for beta thalassemia, baseline hemoglobin of about 11 grams per deciliter, reticulocytes 14%, so quite significant stressed marrow to maintain that hemoglobin level. And the nucleated red cells are between 300 to 600 per 100 white cells, so very significantly stressed marrow. The patient complains of constant fatigue and persistent dental problems. She did achieve menarche at the age of 16, but actually had secondary amenorrhea at the age of 22, and is unable to gain weight for many years. The spleen has been removed in childhood, and pulmonary hypertension and right atrial thrombi are a significant problem in this patient. She has a normal cardiac T2 star and a normal left ventricular function, but her liver iron concentration is actually quite high at 11 milligrams per gram dry weight. And then another patient here who's got very significant extramedullary hematopoiesis. So what you can see with this patient is that this patient started regular transfusions at the age of 4. She became transfusion independent with a baseline hemoglobin of 85 grams per liter on hydroxycarbamide from the age of 19. This MRI scan was taken at the age of 33, and she had presented with a persistent cough and a mild worsening of her anemia with a hemoglobin of around about 80, 78 to 80 most of the time. And what you can see is extramedullary hematopoietic masses pressing on her bronchi, causing the persistent cough, and extramedullary masses here with a massively enlarged liver and spleen. So these are the kind of patients that make the decision to transfuse either very clear-cut or really quite complicated. So the TIF criteria are the confirmation of severe anemia, and laboratory criteria with a hemoglobin of below 70 grams per litre on 2 occasions, more than 2 weeks apart, or laboratory and clinical features with a hemoglobin of above 70, but clear evidence of failure to thrive with facial changes, poor growth, impairment of activity, fractures, and severe extramedullary hematopoiesis. All guidelines recommend that in addition to anemia, clinical symptoms do need to be monitored to make a decision around the initiation of transfusion. So when you start transfusion, what should you do? Well, transfusion frequency needs to be targeted to the patient. Generally, it's between 2 and 5 weekly. The key thing here is that you should be aiming for a hemoglobin of above 90 grams per litre and above 110 grams per litre for patients with heart disease or other medical conditions. And the target post-transfusion hemoglobin should be above 140 generally for the majority. In the non-transfusion dependent patients, occasional transfusions may be required to cover periods of acute infection during pregnancy or in preparation for surgery. And what should we give? Well, we should undertake extended phenotype, clearly the blood group AB blood groups, but also we should do phenotypes for the RH system, which is big C, little c, big E, little e, and cal. And if we can't do a phenotype because the patient's already been transfused, then we should be looking at molecular confirmation of the phenotype. Blood that is transfused needs to be matched for CD and E and cal to reduce the risk of alloimmunization. You should use leukodepleted blood, preferably less than 14 days old. It should be CMV compatible, and clearly packed cells are better than whole blood. This is a very classical table in the TIF guidelines, which clearly states, based on the hematocrit of the packed cells, how many mils per kilo of blood you need to administer for your projected rise in hemoglobin. So what we tend to use in children is we use a calculation, which is the desired minus the actual hemoglobin. We multiply it by the weight, and then we multiply it by 0.3, and that tells us what the mils are that need to be transfused. And this is working on the UK assumption that the hematocrit is about 0.58 for the average packed cell. In children, we should give blood at about 5 mils per kilo per hour. And in adults, we transfuse 1 unit over 90 minutes. In well patients, the Whittington Hospital and UCLH transfuse 1 unit of packed cells over 60 minutes. And we've not had any reported adverse events by doing this. And particularly since COVID, almost all of our patients are being transfused over 3 hours by and large. So transfusion, why can this be a challenge in some patients? Well, alloimmunization is the primary challenge. The frequency is between 4 and 37%. And the contributory factors for this are the age at first transfusion and heterogeneity between the patient and the donor population, particularly around the blood group heterogeneity. And the extent of antigen matching of donor blood, without a doubt, is going to impact on the risk of development of antibodies, and the presence of a splenectomy or not will also impact on the risk of developing an antibody or not. This may be accompanied by an autoimmune destruction of the red blood cells. So if a patient has a strong antibody and you transfuse them blood which contains the antibody, they are likely to have an autoimmune hemolytic process start off, an alloimmune hemolytic process start off. The use of antigen matching for prevention is, there is very good evidence that matching for CE and cal is really important, but this is clearly dependent on resources and inventory available in the countries where the patient is being transfused. What we do know is that if you start blood transfusions at a very young age, less than 1, the risk of alloimmunization is low, but if you're above the age of 1, the risk of alloimmunization is higher across the board in this population. So what are the recommendations? Well, the recommendations are that before first transfusion, perform extended red cell antigen typing of patients. and this is a level 2A recommendation. At each transfusion, give ABO and RHD compatible blood, and where possible, make sure that you are matching for C, big C, little e, and cal. Before each transfusion, you should perform a screen for new antibodies and a cross-match sample. You should use leukodepleted packed red cells with pre-storage filtration if available. And the blood bank pre-transfusion filtration is acceptable if you don't have leukodepletion at source. I just want to say thank you very much for inviting me to speak at the Thalassaemia International Federation conference, and I'm happy to answer any questions.
Thank you very much, Dr. Shah, for that excellent overview. The way we're organizing the meeting is that, as far as I can see, my camera is on. Which browser? Can you see me? Can you hear me? Perhaps in the interest of time, I'll just proceed with the audio and we'll get the camera. Thank you very much, Dr. Shah. We're going to proceed now to Professor John Porter. Please note that all the speakers are standing by and we'll have a Q&A session. Please post your questions, and at the end of the last talk, all the speakers and panelists will take questions. The next speaker is Professor John Porter, who's going to talk on the important subject of iron monitoring and chelation. He's Professor of Hematology, University College London Hospitals in London. Thank you.
Hello, my name is Professor John Porter from University College London, and I'm going to give you a very brief overview of some of the key aspects of chelation and monitoring from my own personal perspective. So if we look at the history of problems from iron overload through the decades, this is nicely shown, I think, in this slide. This is from the UK perspective, and you can see that the causes of mortality have changed radically as chelation has been brought in. So in the 1950s, we had people essentially dying from anemia, but as blood transfusion developed through the 60s and 70s, you were starting to see people running into fatal problems from iron overload, particularly from cardiac iron load and heart failure. So whilst iron overload causes problems all over the body with the endocrine system, growth, sexual development, and ultimately causes liver problems, in the late teens, early 20s, heart failure, cardiomyopathy from iron was and remains a significant issue. As chelation got better with the introduction of desferal initially and then adding deferriprone later in the late 1990s with the approval, all those trials have been going on longer in the UK, and then with XJADE, outcomes improved. And the final column is on the right here, and you can see that the green is gone. We still do see people running into problems with heart failure, but it's much, much less common than it was. And we're starting to see more problems with the liver now because the patients are older. So they run into problems with cirrhosis or liver cancer later in life, from the 40s, 50s, and 60s onwards. So the whole pattern of the problems of iron chelation have changed. And mortality has changed. So whereas in the 1980s, the death rate was about 12.7 per thousand patient years, it's fallen now to about 1.65 if you have adequate monitoring and chelation. Of course, if you don't take the treatment, it doesn't work. And you can see the proportion of patients with iron in the heart, this is in our own clinic, has dropped significantly. So mild to moderate or severe, as shown here, all of these have fallen with time. Now, the concept with chelation therapy is to stop the damage from the iron without causing problems from the chelators themselves. And to some extent, that is a balance. And the balance is different for different chelators, and it's different for different tissues. This is what we have to watch out for. So if we give too much chelator, we can do a number of things. We can inhibit the bone marrow, we can inhibit growth, we can cause problems with the liver, all these things, problems with the kidneys. But if we give too little chelator, we obviously get into problems with failure of the various organs where the iron accumulates. So with monitoring, we're trying to minimize organ damage from iron overload, and we want early trend recognition. If somebody's been doing well, but then they stop doing so well, we need to pick that up. And the commonest way is to look at ferritin trends, but that has its problems. I'll come on to that. But increasingly, actually, we are trying to minimize the problems of overchelation. Because chelation generally works pretty well now, we've got to be careful that we don't get too much chelator into the patient's system relative to the degree of iron overload. And so monitoring helps us with that. So we want to minimize organ damage from iron overload. We want early trend recognition, and we want to avoid overchelation because, for example, with XJADE, if you overchelate, you can run into problems with the kidneys. The tools we use are the serum ferritin, the liver iron measurement, usually using a ferriscan or another well-documented MRI technique, and of course, cardiac T2 star is helpful in identifying those who are at the maximum risk of heart problems. We also monitor for organ dysfunction, problems with the function of the organs, and heart function is really very important. So for example, if someone's got iron in the heart as shown by a low T2 star, they may have a normal heart function or they may have an abnormal heart function. Obviously, those who've got an abnormal heart function are at much greater risk than those with normal heart function. Still needs to be treated aggressively, but there's a different scenario there. Endocrine, we need to make sure that the pancreas is working properly, patient doesn't have diabetes, we make sure the thyroid is working, the parathyroid, we've got to watch all those endocrine systems. And of course, increasingly, we have to monitor the liver for evidence of liver cancer, for example. We would do regular ultrasounds of the liver and also look at something called the alpha fetoprotein, which is a marker of early liver cancer. So this shows one of the problems with monitoring the ferritin. Here we can see the relationship between the shift, the changes, the pattern, the trajectory of ferritin with time, and the pattern of liver iron changes with time. And you can see that when the ferritin is above 4,000, there's a fairly loose relationship between those two. However, when the ferritin is lower, you get a much tighter relationship. So if somebody is well chelated with a low serum ferritin, the ferritin is a much better indicator of the direction of travel. And this is another study where we looked at how helpful the ferritin was in predicting what's going on in the liver. And I don't really have time to go in any detail, but basically a large proportion of patients where the LIC, the liver iron, is actually responding, you don't actually see a response in the ferritin. So you do need to include liver iron measurements alongside your ferritin measurements. And we would do it at least yearly, depending on the circumstances of the patient. So looking at the liver iron is important because it can identify trends with body iron, which can be missed with the ferritin for various reasons. It can tell you the total storage iron in the body from a formula that was worked out by Angelucci. It can identify those patients who are least likely to run into problems. We also need to look at the enzymes. If the liver enzymes are abnormal, this may require investigation. And we also know that when the liver iron is very high, there's a much higher risk of a heart iron occurring. Increasingly, we're seeing problems on others. This is not our own work here. This is showing liver disease through time. And we can see that liver disease is becoming more and more of an issue in thalassemia patients. We know that liver can be well controlled with XJ. This is a large study we did with Donier and others, which shows that XJ can control fibrosis in the liver and can actually reverse it in many cases. So why don't we just use the ferritin and the liver iron measurement? Well, of course, it doesn't identify patients with cardiac iron, and the cardiac T2 star is key here. And we know that when the cardiac T2 star is abnormally short, that is less than 10 milliseconds, we have a higher risk of the patient going to heart failure in the next year. And when it's less than 6 milliseconds, you've got a 50% chance of developing heart failure in the next year. So of course, this is part of the monitoring. It's got to be done properly, and that's another subject. Now, the tools we still have 3 registered chelators, licensed chelators: Desferal, Deferapro, and Deferosarox. I don't have time to read all those out because of the short presentation, but we have to monitor for the particular problems that we get with each chelator. Each of them has slightly different tolerability profile. So generally speaking, philosophically, we're trying to do 2 things with chelation. We're trying to prevent problems, and then unfortunately, we're trying to rescue people if they run into problems and haven't been taking the right amount of chelator often enough. So very broadly, we're trying to balance input and output with transfusion and chelation, and adjust the doses accordingly. Dose is really important. People tend to say, oh, I'm on this or I'm on that. It's not as simple as that. How much are you on and how often are you taking it? So just because you are on, in inverted commas, something doesn't mean that it's going to work, because the amount that you take is absolutely key. And we've done very careful work relating the dose of, for example, Desferal or XJ to the amount of iron you excrete. And we can usually predict from the transfusion rate what is going to be needed. Of course, that doesn't factor in how often the drug is taken. Increasing the dose does improve control of iron. And so you can see in a large study here of 472 patients, when the dose was relatively low, the ferritin went up, and when the dose was increased, the ferritin went down over a period of time. That's something you'd expect, but you need to know that relationship actually quite well to make the right decisions. I'll finish by talking about rescue. Now, fortunately, we don't need to rescue patients as often as we used to, but we do need to identify people who are getting into problems with cardiac iron, for example, so that we can intensify. Also, when people are getting into problems with their liver as well. Now, this is a point that's often not made, and I just wanted to make this point, is that the level of liver iron in the patient, the ferritin to some extent, and the liver iron as measured, does have an influence on how well you can improve cardiac iron. And when you're looking at how different chelators work, you do need to see what the starting liver iron was, because the improvement in cardiac iron is very much predicated by the liver iron concentration. Here, this is well known that this is a study where Deferapro was compared with Desferal, but actually here a relatively low dose of Desferal was compared with a relatively high dose of Deferapro. So the devil's in the detail. How iron overloaded are these patients when you start, and what doses are being used? This is a study with XJ showing improvements in cardiac iron, T2 star, with a progressive treatment. XJ works for that as well. This is early work I did with Bernard Davis, and this was showing improvement in heart function in people who get into problems. So many patients with iron in the heart will have normal heart function, but when you get into problems with the heart function falling, you need to intensify. And the treatment that works best is intravenous desferrioxamine, as shown here. Here's another study where we looked at both T2 star and heart function. And what you could see is, whereas the heart function improved over 12 months with intravenous Desferal, the iron improved over 12 months, the heart function improved relatively quickly. So there isn't a straightforward relationship between heart function and cardiac T2 star. We then did a prospective study comparing combination therapy with Desferal alone. We didn't show much difference, but we still recommend adding deferriprone where possible to these patients, to the continuous intravenous iron preparation. Increasingly, people are interested in combining, and the original combination was deferriprone and Desferal, but now there is increasing experience of using other combinations, and here we modeled these different combinations in the laboratory, and we came to a view that combining deferriprone with Exjade would be a useful and effective combination. And you can see here from the work by Alalfi that it's actually a particularly useful combination, both in decreasing overall body iron, but also improving cardiac MRI, cardiac T2 star. So to summarize, chelation is a very effective modality if it's taken at the right dose and taken consistently. And one of the things I didn't have time to talk about is how you can work with patient groups and individual patients in the clinic to really try and help people to take what is sometimes a demanding treatment every single day. Monitoring ferritin trends is useful, but you can be careful monitoring that. We didn't go in great detail, but monitoring ferritin is important. We need to check against a validated method for measuring liver iron. If the way you're having your liver iron measured is not properly validated, it's a waste of time and waste of money. And I'm very keen to improve the overall way that MRI is used to help people monitor their iron status. The same is exactly true with cardiac T2 star cardiac iron. Monotherapy, a single drug, can be effective at controlling liver iron, rather more so with Desferal and deferriprone than with monotherapy with deferriprone. Generally, with deferriprone, you need to add a second chelator to control the liver iron. With regard to cardiac iron, monotherapies can be good, but in severe cases, you're going to need to do some kind of combination, and I whistled through a couple of those. And finally, heart failure requires a continuous Desferal infusion once heart failure has developed, and then deferriprone can be added where necessary. Thank you.
Thank you, Professor Porter. That was an excellent presentation, an excellent overview on iron chelation by one of the international experts in the field and one of the editors of the recent guidelines on transfusion-dependent thalassemia. So may I remind you that we really need your questions. There will be a Q&A session at the end of the presentations, and this is a great opportunity to address any questions you have to the experts that are speaking in this session. So let's move to the next speaker, Professor Malcolm Walker. Malcolm Walker is a professor of cardiologist at the University College Hospital in London and one of the few experts on thalassemia heart disease. Professor Walker.
Hello, I'm Malcolm Walker, I'm Professor of Cardiology at University College Hospital, London. Thank you to the TIF organisers to invite me to address you on what I believe to be a very important topic, that is cardiac complications in thalassemia. I'm going to divide those simplistically into those due directly to iron overload and those which have a less direct association. Those due directly to iron overload, the most feared complication being heart failure, which complicates acute iron toxicity and results in a reduced pumping function or ejection fraction, the so-called heart failure with reduced ejection fraction, with the awful acronym that's given. This severe condition is potentially life-threatening and therefore has figured very largely in the thoughts of everybody dealing with thalassemia patients. There is another syndrome or phenotype, and this is a consequence of chronic or indeed historical iron overload with the additional long-term effects of a chronic anemia, and other comorbidities such as diabetes. And this produces a complex, variable cardiac phenotype, including what we'd call a stiff heart, restrictive physiology or diastolic dysfunction, given the acronym heart failure with preserved ejection fraction, or HuffPuff. This is more chronic and less acutely threatening to life. And you might imagine these two phenotypes require somewhat different therapeutic approaches. I also want to directly discuss iron overload-induced arrhythmias, and those would be the tachycardia, such as ventricular tachycardia and AF, that complicate acute toxicity, and complete heart block. And then importantly, I introduce the idea of a late consequence of previous iron overload, which is atrial fibrillation, which we're now commonly seeing in our older thalassemia patients. There are changes in vascular compliance, but these aren't terribly well characterized, and the consequences are unclear, although they undoubtedly will add to the tendency to a stiff heart or restrictive physiology. And what about those not directly due to iron overload? The main one that we'll discuss is pulmonary hypertension, which in the transfusion-dependent thalassemic occurs in about 2 to 13% of patients, which is very high compared to a non-thalassemic population, but much less than that encountered in non-transfusion-dependent patients, where it may be up to 14%. The mechanisms are complex and variable, but they involve intravascular hemolysis, exacerbated perhaps by late left ventricular dysfunction, and particularly the restrictive physiology that I previously mentioned. And importantly, in this group as well, is the effect of chronic thromboembolism, which may be natural due to their prothrombotic status, or iatrogenic due to long lines. There are cardiac arrhythmias appearing late, especially atrial fibrillation and some degrees of conduction disturbance, which may not be directly related to acute iron toxicity. So what does it look like for the patient? Well, this is a two-dimensional echo of a 27-year-old woman on monotherapy with deferoxamine with very few symptoms but high iron loading. And you can see here very poor pumping, ejection fraction just 15%. And what happens here? The patients are admitted to hospital, hopefully somewhere with experience in managing these patients. But the most important therapeutic intervention is the immediate adoption of intravenous 24 hours, 7-day-a-week intravenous deferoxamine. As soon as practicable, the guidance is to add an oral agent in the form of deferriprone. It's important to give supportive hemodynamic therapy with the caveats that you have to be cautious with diuretics and inotropes. You have to be meticulous in the management of diabetes and electrolytes. And you have to cardiovert early for tachycardias in order to stabilize the hemodynamics. You'll want to consider other interventions as listed below to optimize the patient's treatment. Early on, this is a paper published by Lisa Anderson from our group, showed that with intravenous chelation, you could show an improvement in ejection fraction and a reduction in the heart size. And this was also shown with longer-term intravenous deferoxamine by Professor Porter and Bernard Davies, with this longer-term beneficial effects by removing the acute toxic effects of iron. And here we've shown in another study from our group, showing how the improvement in cardiac function in the left panel, the ejection fraction rises across time in direct parallel nature to the rise in T2 star. The higher the T2 star, the less the iron, so that the improvement in function mirrors the reduction in cardiac iron content. And this is what you end up with. This is the same patient nearly just over a year later with normal cardiac function. However, it's going into decompensated heart failure has a poor outcome. We see it very rarely these days, so I'm hesitant, but mortality is high. And there is some historical data from series, this one was from Greece, of as high as 48% mortality within 5 years of people who decompensate. And you need these kind of iron levels, 3 to 9, to produce this severe acute toxicity. However, what's really important is that recovery can be complete and can be long-lasting. But it's important for clinicians to emphasize to their colleagues and to their patients that prevention is the only way to deal with this and prevent it occurring. There's another phenotype which is illustrated here in the left panel. Here's the cross-section to the left ventricle in a patient with ejection fraction which is just subnormal at 56, heavily iron overloaded, T2 star less than 6, no symptoms. 3 years later, the intensified treatment was not complied with. And now you've got remaining high iron loading, still no symptoms, but cardiac function has dropped. This is clearly a worrying scenario that requires intensification of chelation and consideration of other cardiac medication. The risk with iron was quantified by this paper from Paul Kirk and our group, showing that there's a dose response. The lower the T2 star, that is the higher iron content, the higher your risk of heart failure within a year, so that the risk was at 47% if your T2 star was less than 6 milliseconds. The good news is that all 3 chelators are effective at cardiac iron removal if you give them at adequate doses and the patient's able to take them. And nowadays, with 3 choices, therapy should be tailored to the individual. Combinations of therapies which now have regulatory approval are also particularly helpful in dealing with cardiac toxicity. What is less clear is the role of conventional cardiac therapies such as beta blockers, renin-angiotensin, aldosterone systems, drugs. So we know it's not appropriate to withhold these drugs because they're evidence-based in heart failure. But the duration of therapy, once left ventricular function is normal and iron overload resolved, this is not established. And they're not always easy drugs to use in this group. So we need more research. To deal with cardiac arrhythmia, then again from the Kirk paper, and this was the prevalence of arrhythmia, about 12% for AF, as you can see, much the commonest rhythm. And there was a relationship so that the lower the T2 star, the higher the risk of arrhythmia. So 20% risk with the T2 star under 10 milliseconds. Our colleagues in Italy from the MIOT group, Alicia Pepe and her colleagues, they found a lesser incidence of arrhythmia. And I'm not sure what the cause of this change is, but clearly still an issue. Bradycardias and heart block, complete heart block, in our experience, is now extremely rare. And all the cases that I'm aware of are associated with very heavy iron overload, as in the pre-chelation literature. Usually, these patients respond quite briskly to intensification of chelation with intravenous deferoxamine and iron removal. They occasionally require pacemakers, and these have to be MRI compatible, which I'm pleased to say is now the default therapy that is used. More worrying is the development of arrhythmias such as this. This is a broad, complex ventricular tachycardia that we picked up in a 29-year-old man with, again, iron loading, poor compliance, but normal left ventricular function. His palpitations were palpitation associated with dizziness. In our experience, VT is very rare, but it is potentially a medical emergency because of its association with sudden death. Again, the response is to intravenous deferoxamine, as this is an acute toxicity effect of iron. You may need to consider an ICD, particularly in patients with poor ventricular function, and this has to be, and thankfully nowadays, would be an MRI-compatible device and leads. Mostly you can hold off device therapy in these young patients as the condition tends to respond to iron removal. However, in some patients, you do have to consider that approach. Atrial fibrillation, well, in the younger and particularly in iron overloaded patients, it may be the precipitant of decompensated heart failure and therefore needs urgent treatment, for instance, DC cardioversion, without waiting, particularly in decompensated patients. In this group, it's a marker for the need of intensification of chelation, and you should still consider anticoagulation in this group of patients. And you need to know the left ventricular function and the iron burden in these patients in order to manage them optimally. In the more chronic situation, this is our experience, atrial fibrillation may occur in anywhere up to 40% of the older thalassaemic patient. And from the panel on the right, it doesn't appear to be associated with current iron loading. However, the patients with atrial fibrillation tended to have a history of higher iron in the past. So that my interpretation is atrial fibrillation occurs late in life, and it reflects a past history rather than any current iron status. So far as conclusions where arrhythmia is concerned, excuse me, they have a complex pathophysiology, and this is different according to the age and iron loading, and of course I haven't put there, but also ventricular function. You must have intensified chelation in most instances. That may prevent the problem and control it completely. You might need to consider cardiac medicines, and certainly anticoagulation should be considered, particularly in the older groups. The role of the more interventional procedures is not fully defined, but in our experience, it can be successful, although it's a bit more difficult in this group, and all devices need to be MRI compatible. For the last couple of minutes, I just want to consider complications not directly due to iron overload, specifically pulmonary hypertension. The risk, as I've mentioned before, and the mechanisms include intravascular hemolysis, the effect of a restrictive left ventricular physiology, chronic thromboembolism, and iatrogenic from unanticoagulated long lines. We've seen all of these contributing to pulmonary hypertension. Here you have, from this review published some years ago, another group of clinical risk factors in this group. The measurement is ideally by non-invasive echocardiography, which if you do it properly, you'll get a very clear envelope of velocity across the tricuspid valve. And when you do the technique properly, the correlation, as you'll see in the bottom right panel, the correlation with cardiac catheter-based measurements is extremely tight. However, there are problems. About 20% of our patients don't have a tricuspid jet from which you can measure velocity. And if there's a lot of tricuspid regurgitation, the measurements are not accurate. It's very operator dependent, and there is subject to errors, particularly when you try and convert a velocity to a pressure drop. And I would suggest to individuals that they stick with the velocity measurement, as that's the most accurate, rather than multiplying the squared velocity by 4, which you can see will increase your errors. Definitions are a bit difficult in this group, and possibly a tricuspid jet velocity greater than 2.9 is above normal, but it's very variable across time. What is clear is that we need to screen our patients regularly and to ensure that it's not developing because of poor left ventricular function that needs support from cardiac medication. You need to assess the right ventricle very carefully, and you need to exclude iatrogenic causes. Treatment, reducing hemolysis, prevent thromboembolism, and you then also consider vasodilators. If my slide moves on. So conclusions. Heart iron is determined by the rate and duration of transfusion therapy, as well as the type of and pattern of chelation. The heart can buffer iron to keep free iron levels low, but this creates a state where you have high iron on the MRI signal, but normal function. Symptoms or decompensation develops when the buffering capacity is exceeded, or you damage them with intercurrent illness. Prevention of this load is the fundamental approach, and early diagnosis of rare but serious complications. You need to have the programs that can pick these up. Finally, there's been a documented improvement in the cardiovascular output for thalassemia. The MRI scan has improved the precision, and new faster sequences that I haven't had a chance to talk about today hold the promise of increasing the availability and accuracy of MRI. You need the conventional tools to make a complete assessment of your patient, and the improved outlook is related to better treatments specifically with the chelators, but also other cardiac medicines. And as the cohort ages, there are new challenges: atrial fibrillation in the older patient, the development of the heart failure with preserved ejection fraction phenotype, pulmonary hypertension. We need vigilance, we need a comprehensive prevention strategy, and more research to optimize all the gains that have been achieved by using chelation. And as I tell my patients, just because they're thalassemic doesn't render them immune to the societal influences on our health. They have to be careful and avoid becoming fat, lazy, and eating poorly. So with that, I will end. Thank you very much indeed for listening.
Thank you very much, Professor Walker, for that excellent overview of the gains made, as well as some of the challenges. Our next speaker, and I'm delighted to introduce him, is Professor John Koskinas. He is a Professor of Hepatology and Medicine at the University of Athens Medical School, and he's going to talk on liver disease and liver complications. Thank you.
Dear colleagues, dear friends, good morning. I would like to thank the organizing committee for this kind invitation to talk about liver diseases in thalassemia. This is my conflict of interest slide. You are aware of the many complications from many organs in thalassemia due to chronic anemia, blood transfusion, and iron overload. In the past decade, the main cause of death in patients with thalassemia was iron overload and its complications mainly from the heart. You can see here that after the implementation of a very effective chelation treatment, there is a decrease in the heart disease-related mortality. However, we can see a relatively increase in liver disease-related mortality. What are the causes of liver diseases in thalassemia? There was iron deposition, chronic hepatitis C or chronic hepatitis B infection, alcohol and non-alcoholic steatohepatitis due to obesity, and congestive heart failure. Now let's talk about hepatitis viruses. They can cause acute infection, and some of them, they can progress to chronicity. From patients with chronic hepatitis, 20 to 30% of them, they may develop cirrhosis over the years, and consequently decompensation and development of hepatocellular carcinoma. In patients with underlying liver disease, and particularly those with cirrhosis, we should treat the underlying liver disease to avoid progression and decompensation. And also, we should take measures to prevent or treat the acute causes, the acute insults, like acute hepatitis A, acute hepatitis B, or hepatitis C, that may cause acute and chronic liver disease and failure. Hepatitis A virus is transmitted through contaminated food and water, through fecal oral route, and it is usually asymptomatic in the majority of patients. It could be very serious in patients with underlying liver disease or hepatitis C infection or diabetes. So all individuals with chronic liver disease should be vaccinated with hepatitis A vaccine, who has a very high efficacy. Hepatitis E infection is transmitted in endemic areas through fecal oral route, mainly through contaminated water, and in non-endemic areas through uncooked food. In the majority of patients, the acute infection is asymptomatic, but it can cause high mortality in infected pregnant women, up to 25%, and it may cause as well acute and chronic liver disease in patients with underlying liver disease. So prevention is mandatory to avoid consumption of uncooked food, hand washing, and nationwide screening has also been introduced in some countries to avoid transfusion-related transmission. Hepatitis B infection is transmitted from one person to another through contaminated blood or through sexual intercourse or from infected mother to infant. Chronic infection with hepatitis B could result in chronic hepatitis in half of these individuals that consequently may progress to cirrhosis or decompensation or development of hepatocellular carcinoma. Now, decision for treatment for hepatitis B is based on biochemistry, viral replication, stage of fibrosis, other liver diseases, age, and family history of hepatocellular carcinoma. We do have a very effective antiviral treatment, nucleoside analogs, that they suppress the virus and we can have normalization of aminotransferases and undetectability of HBV DNA. We do have a very effective and safe vaccine for hepatitis B infection, and we should vaccinate all the general population and the special groups particularly, and those patients with underlying liver disease, like patients with thalassemia. Now, what about the prevalence of hepatitis B in thalassemia patients? It is estimated to be between 0.3 to 5% of thalassemia patients. But HBV does not seem to be important in the etiology of cirrhosis, and HCC in patients with thalassemia, at least in the West, from studies from Italy and Greece, we don't have enough data from patients coming from high endemic areas. So effective vaccination programs and treatment of hepatitis B with antiviral drugs is very important. Now, chronic hepatitis C infection, the prevalence of positive antibodies is ranging between 15 and 75% worldwide. From those, viremic are 78%, and this prevalence, it is estimated between 20 and 25 in Europe and up to 70% in the Middle East. In the past, there was an increased risk of transmission through transfusion before 1990, but nowadays it is very rare to get hepatitis C infection through transfusion due to molecular screening. And this is the progression of fibrosis in patients with iron deposition and hepatitis C, and you can see in the presence of both of these, hepatitis C and higher overload, you get really a very fast progression of fibrosis. What about treatment for hepatitis C? We do have a very effective pangenotypic first-line drugs that are given orally. They are with high efficacy, more than 95% clearance of the virus after 3 months of treatment. These drugs are quite safe, there are no side effects, and there is no drug-in-drug interaction with the iron chelating drugs. Here you see the results of the microelimination program we have implemented in the region of Attica, 50% of the population in Greece, from 7 centers, and all the patients, all the thalassemia patients, they have been treated with first or second line treatment successfully. Now let's talk about hepatocellular carcinoma in thalassemia. This is a multi-center study, and the prevalence of HCC, it is estimated to be in transfusion-dependent thalassemia patients, 1.6%, with a median age 36 years. Hepatocarcinogenesis, as you know, it is a multi-step process, and it starts from chronic hepatitis, and then the development of dysplastic nodules, and then with genetic and epigenetic changes, the development of early hepatocellular carcinoma. Now, what are the causes? Are the causes of hepatocellular carcinoma the cause of the underlying liver disease as well? Hepatitis B and hepatitis C, we have discussed these viruses. Now let's talk about the iron overload and the immune system. We do have an example from patients with hereditary hemochromatosis, where because of the mutation, you have a very low level of hepcidin, So you have an increased absorption from the enterocyte, increased iron absorption, that it is deposited in many organs, and particularly in the liver. What's the prevalence of hepatocellular carcinoma in these patients? 2.5% per year, and 10 to 15% per year in patients with established cirrhosis. Now, free iron is very deleterious. It can cause lipid peroxidation and cellular death, or it can increase the collagen synthesis from the asteroid cells of the liver and increase fibrosis. Iron induces carcinogenesis directly through oxygen radicals after the Fenton reaction, and this can really induce carcinogenesis by direct effect. Iron also promotes cancer, and you can see here that a cancer cell with iron has a high tolerance against oxidative stress and does not go to apoptosis, so the daughter cancer cells have a higher malignant potential due to the presence of iron. Iron can affect the immune system by decreasing the antibody-mediated phagocytosis by the macrophages, inhibits lymphocyte proliferation, modifies the lymphocyte distribution in different compartments of the immune system, and also can inhibit CD4 lymphocyte function and cause an unbalance of immunoregulation in the microenvironment. And you can see here the importance of iron in the microenvironment in the immunosurveillance of HCC. Now, iron and hepatitis C have a synergistic effect, and the presence of hepatitis C can increase the transport of iron from the cytoplasm to the mitochondria and then increase production of oxygen radicals. Now, let's see some clinical studies regarding hepatocellular carcinoma. This is the Italian registry. You can see that among the 62 individuals with hepatocellular carcinoma, 70% they were viremic for hepatitis C, and 5% they were positive for hepatitis B surface antigen. And in patients who had non-viral hepatocellular carcinoma, they found increased levels of iron in the liver. The median survival was 11 months. And you see here, in patients with non-viral hepatocellular carcinoma, you see here that these patients, they didn't have cirrhosis, but they have increased levels of iron deposition. What about our registry regarding 42 patients? Here you see the mean age of these patients, 45 years, as compared to 56% in the general population. 60% they were viremic for hepatitis C. Cirrhosis was present in roughly 80% of patients, and important as well that 60% of the individuals had alpha-fetoprotein levels less than 100 nanogram. And the most important prognostic factor was the stage, the early stage of hepatocellular carcinoma, stage A by Barcelona classification. So it's very important to diagnose hepatocellular carcinoma at a very early stage. You see here the characteristics of HCC in patients with thalassaemia, the young age, they are frequently multinodular, and they are biologically quite aggressive. They can develop in the absence of hepatitis C, in the absence of cirrhosis, and in the absence of severe hemosiderosis, at least at the time of diagnosis. So as I said, it's very important to screen our patients for hepatocellular carcinoma and diagnose the hepatocellular carcinoma at very early stage, where we do have a very curative treatments that can increase the survival up to 5-year survival up to 70%. How you assess liver disease in thalassemia? You assess the iron by ferritin and MRI. You can assess the viral infection by serology and molecular screening, and you can increase with different methods the stage of fibrosis. Here you can see here the ultrasound and triplex and the fibroscal that we can assess liver fibrosis. And transient elastography, fibroscan is a very reliable tool for assessing liver fibrosis. It can be overestimate the findings as a result of high iron levels, congestive hepatopathy, and high aminotransferases. Here you see the evaluation of iron in the liver by MRI and with liver iron concentration leak, which measures milligram of iron per gram of liver tissue. And you are aware of the very effective iron chelators. And this is the results of treatment with iron chelator, deferasirox. And you can see here that 83% they have reversion or stabilization of liver fibrosis after 3 years of treatment. To conclude, this is the recommendations. We should assess the liver iron and have systemic iron chelation therapy. We should treat chronic hepatitis C infection if present with direct acting antivirals, and we should treat, if necessary, chronic hepatitis B infection. For hepatocellular carcinoma surveillance, liver ultrasound with or without contrast every 6 months is mandatory, independent of the presence of, in all patients, independent of presence of cirrhosis by a very experienced radiologist. We should vaccinate patients for hepatitis B and A after serological testing, and we should inform and educate our patients about the transmission routes of hepatitis virus and the precautions they need to take for prevention. And here you see the recommendations in the 2021 guidelines. Finally, and very important, we should educate our patients because, as the great philosopher Aristotle said, that don't treat me like a fool, but first explain to me the cause of the disease, and then I will be convinced and I will comply. Thank you for your attention.
Thank you, Professor Koskinas, for this excellent overview of liver disease in thalassemia and the important challenges now that we face, like hepatocellular carcinoma. Now, let's move to our final presentation. Please post your questions. It is an excellent opportunity to ask the experts, and we will address your questions at the end of the session. So the last speaker is Professor Evangelos Terpos. He's an hematologist, a professor of hematology at the University of Athens Medical School and the Alexandra Hospital in Athens, Greece.
I'm Evangelos Terpos from the National and Kapodistan University of Athens, Greece, and I would like to thank the organizing committee for the kind invitation to present the bone disease in thalassemia issue and discuss the management of these patients. These are my disclosures. And as you know, osteoporosis is prevalent in adult patients with thalassemia, present in the lumbar spine at almost 90% of the patients, in the hip in 60% of the patients, and in the distal radius in 73%. The incidence is 40 to 60%, and we have a mean annual change in the lumbar spine BMT of 1.36% of reduction. You know very well the definition of osteoporosis according to the WHO, which is defined as a BMT score below the minus 2.5 times, leading to higher risk of fracture, and the specific definitions for osteopenia, and of course the normal BMT. And we have also the zeta score, which is the number of standard deviation that the patient's bone mass is above or below the mean bone mass of age and gender matched control. For the T score, we talk about the number of standard deviation that the patient's bone mass is above or below the mean peak bone mass of a 30-year-old healthy woman. And I think that this is very important. You know that, the level of osteoporosis correlates with the fracture risk, as you can see here. So between below 2 and below 3, you can see that the fracture risk is increased substantially, especially at the level of below minus 2.5 times of standard deviations below the standard for a woman of the age of 30 years. And you can see that the fracture risk is very high. The clinical factors in the pathogenesis of thalassemia-induced osteoporosis includes the bone marrow expansion with the mechanical interruption of the bone formation, the imbalances in multiple endocrine pathways that can alter the bone metabolism, like hypogonadism and defects in growth hormone, the iron overload and the chelation therapies, and the deficiencies in vitamins and minerals, especially vitamin D deficiency and zinc deficiency. In order to understand what's happening in thalassemia patients with osteoporosis, you need to have a little background of the normal bone metabolism. We have the osteoblast that produce the new bone and the osteoclast that resorb the old bone, but the most numerous cell into the bone are the osteocytes. The osteocytes are osteoblasts that entombed into the bone matrix that have produced, and they are transformed to this cell that communicate to each other with this microcanalischi. Every time that we have a microcrack, and this happens almost 20 or 30 times in every cubic centimeter in our vertebral bodies, for example, we have the disruption of the communication of the osteocytes, and the osteocytes goes into apoptosis. This is extremely important in order the bone metabolism to start. You can see here the microcracks, we can see them in murine models of osteoporosis, and you can see here the osteocytes that link to each other with this microcanalischi. When we have this disruption, the healthy osteocytes goes to apoptosis, and you can see that the apoptotic osteocytes have this this pattern with these vacuoles that are full of cells like that includes rank ligand, sclerostin, and other important molecules, and this is a necrotic osteocyte. You can see here a microcrack. When we have the microcrack, we have the activation of the osteoclasts that come to the area in order to resorb this old bone. And you can see that the osteoclasts, like the jellyfish, resorb this old bone in order to leave behind a hole that is filled by a new bone by the osteoblasts. The most potent osteoclast activator is the rank ligand, the receptor activator of nuclear factor kappa B ligand that is produced especially by the osteocytes when we have these microcracks, and the rank ligand binds to rank on the surface of perfusion osteoclast. Don't forget that the perfusion osteoclast is originated by a macrophage colony forming unit. So a stem cell that gives birth to macrophages, dendritic cells, and osteoclasts. The binding of rank ligand to rank enhances the differentiation of perfusion osteoclast to mature osteoclast, and this binding in mature osteoclast inhibits the osteoclast apoptosis. So if we don't have rank ligand in this mouse model, we can see that we have osteopetrosis because we don't have bone resorption. Like every important cytokine in nature, rank ligand has an inhibitor, and this inhibitor is called osteoprotegerine. It is produced by the osteoblast. It binds rank ligand, and it inhibits everything that I previously described, because this binding inhibits the other binding of rank ligand to rank. When we don't have osteoprotegerine, like in this OPG deficient mind, we have osteoporosis and osteoporotic fracture and very low bone volume. So the ratio of rank ligand to osteoprotegerine drives the osteoclast activity in all bone disorders, and it is the same in osteoporosis due to thalassemia major. So the rank ligand to OPG is reduced and in favor of rank ligand in patients with osteoporosis compared to controls. And we published that with Ersi Boscarido many years before. As I see now, it's 18 years before. And I think 1 year after, Morabito and colleagues published same results, exactly same as you can see here, median levels of OPG to rank ligand in patients with thalassemia major and osteoporosis. We have measured a lot of markers of bone resorption and formation in thalassemia patients. I have to stress the 5-benzoenzyme of TRAP that gives you the idea of the osteoclast activation, and the collagen type 1 telopeptides, either the amino or the carboxy telopeptides that are the degradation products of the main protein of the bone, the collagen type 1. That is when we have increased resorption, we have elevated levels. And also we can measure the bone alkaline phosphatase, the collagen type 1 propeptides, and osteocalcin, that are enzymes that are produced by the osteoblasts and are the markers of bone formation. We have shown that bone resorption markers are elevated in patients with thalassemia, while bone formation markers also are elevated, but at a lower level. So we have osteoporosis in patients with thalassemia. And furthermore, all the pathways that drives the osteoblast activity, like the insulin growth factor, the Wnt signaling, all of them are altered in patients with thalassemia. First of all, the insulin growth factor 1 growth hormone axis is important for the osteoblast function, and you all know that due to hypogonadism, this is altered in patients with thalassemia. You can see here that the IGF-1 levels are very low in patients with thalassemia compared to controls. And the DCOP1, which is an inhibitor of the Wnt signaling. Wnt signaling is important also for the osteoblast function, is altered in patients with thalassemia. You can see here that the cortical thickness in patients who have no DCOP1 is altered and reduced. You see from our publication some years before that DCOP1 is elevated in patients with thalassemia compared to control, and the levels of DKK1 correlate with the increased bone resorption and also a negative effect with bone formation marker, because the DCOP1 inhibit the osteoblast function, so the elevated levels inhibit the osteoblast function. Are the acquired factors adequate to induce osteoporosis? The problem is that thalassemia major patients continue to present bone loss, even if there is adequate transfusion and chelation programs, hormonal replacement, and absence of other factors contributing to the development of reduced bone mineral density. So we do know that polymorphisms in specific genes, like the collagen 1 gene or the vitamin D receptor or the transforming growth factor beta, are important and correlate also with the development of osteoporosis in patients with thalassemia. During the last years, we know that piezo-1 is a major skeletal mechanosensor that tunes bone homeostasis, and in response to mechanical loads, the piezo-1 in osteoblastic cells control YAA-dependent expression of type 2 and 9 collagen. And you can see here that the loss of piezo-1 in osteoblastic cells resulted in increased bone resorption. So you can see here the increased bone resorptions in piezo-1 null mice compared to the normal ones. And we have seen that the loss of piezo-1 is not only correlated with osteoporosis, but also with low bone volume, with low bone trabecular levels, and also with enhanced osteoclast function. The mechanical force induces bone formation by down-regulating sclerostin through the piezo-1 ACT pathway, and you can see here that any mechanical load due to the piezo-1 enhances the production of sclerostin. That is another Wnt inhibitor that inhibit the osteoblast function. And you can see here that sclerostin, when we have the overproduction of new bone by the osteoblast, this mechanical load make the underneath osteocytes to produce sclerostin that inhibit the osteoblast function. And we have seen that sclerostin is elevated in patients with thalassemia, not at the level of postmenopausal osteoporosis patients, but at higher level compared to control of similar age and gender. And we've seen that the sclerostin levels correlate with the enhanced loss of bone in the lumbar spine and in the zeta score in the distal radius. So the PGO1 has an emerging role in thalassemia because it regulates the bone turnover. It plays an important role in red cell hydration and an important role in hepatic iron metabolism. What are the treatment options that we have for the thalassemia-induced osteoporosis? The prevention, the general principle, hormonal replacement, calcitonin, bisphosphonate, and denosumab are very important. Now we have also luspatercept that may play an important role in bone metabolism. First of all, we do know that pamidronate and improve the lumbar spine bone mineral density at the level of 30 milligrams per month. This was sufficient to increase bone mineral density, and this is a more recent publication by Dr. Chatterjee showing that patients with beta thalassemia and osteoporosis who received pamidronate managed to increase, as you can see here, after 3 years, the bone mineral density zeta score in the spine and in the total hip. We have designed a study some years before with zoledronic acid in patients with thalassemia-induced osteoporosis, giving either placebo or zoledronic acid 4 milligrams every 3 months or every 6 months. And we have seen that when we give the zoledronic acid every 3 months, we have much better results compared to placebo. And you can see here the lumbar spine baseline levels, what happened after 12 months and after 3 years. We have a dramatic increase in the T-score in the lumbar spine, but also in the femoral neck, which is much higher compared to every 6 months duration administration. The 2 doses of denosumab, on the other hand, at the dose of 60 milligrams every 6 months versus placebo, managed to increase compared to placebo, but not compared to zoledronic acid, managed to increase the lumbar spine and the wrist bone mineral density. Denosumab increases that because it inhibits the osteoclast function, but also we've seen that it creates a significant increase in noggin serum levels. And noggin is a negative regulator of bone morphogenic proteins, which is extremely important. We've seen very nicely the correlation between the change in noggin protein and the bone mineral density in the wrist, with an R of 0.64, minus 0.64, and possibly the denosumab, due to the regulation of noggin, favor also bone turnover in thalassemia patients with osteoporosis. Activin is another promoter of osteoclastogenesis and inhibitor of osteoblast function. Activin A is a transforming growth factor beta superfamily member. We have seen that activin A correlates with the lumbar spine bone loss in thalassemia, and luspatercept, which is an antagonist of TGF-beta, may play an important role in that. So in order to conclude and to be on time, we can say that thalassemia-induced osteoporosis is multifactorial. The reduced osteoblastic activity, which is believed to be the basic mechanism of bone loss in thalassemia, is accompanied by a comparable or even greater increase in bone resorption through the rank ligands, rank OPG, and activin pathways. DCOP1 and sclerostin seems to be implicated in the pathogenesis of osteoblast dysfunction in this setting. IGF-1 plays an important role. The role of PGO1 is also important in thalassemia. Monitoring bone mineral density with DEXA scan is especially important in adult patients with thalassemia. Bisphosphonates effectively restores bone mineral density and reduces pain in thalassemia patients with osteoporosis. They are well tolerated, and the benefits continue for even more years after the stop, especially for zoledronic acid. Denosumab may be another option in this setting. Possibly we need higher dose than the approved one, but we need to further investigate that. And luspatercept also seems to play an important role, not only in increasing the hemoglobin, but also in improving the bone metabolism in thalassemia patients. And with that, I would like to thank you so much for your attention, and I'm happy to have questions. Thank you.
Thank you, Professor Terpos. That was an excellent overview of bone disease in thalassemia. We have about 5 minutes for questions. Please keep posting your questions. There is first a question for Dr. Shah. Dr. Shah, can you hear us?
Yes.
Okay, so there is a question for you. Is there recommending, I think you have covered that in your presentation, but I will anyway pose the question, is there a recommended starting dose at starting level of for hemoglobin for regularly transfused thalassemia patients?
Yes, so we in the UK would recommend a hemoglobin, and the TIF guidelines also recommend a hemoglobin of between 95 and 105 pre-transfusion for people who are on regular transfusions. It's important not to confuse the transfusion trigger for when you start transfusions for the very first time. Those guidelines recommend a hemoglobin of or failure to thrive. But once you've started patients on transfusion, you need to keep the pre-transfusion hemoglobin at a good level to prevent complications.
Okay, thank you. Now, since you have the floor, there is another question for you. How often are transfusion reactions occurring in thalassemia patients, and what about the long-term effects of TRALI?
So in the UK, we use packed cells, and they are leukodepleted at source. We very rarely see significant transfusion reactions in our patients, particularly since we've been doing leukodepletion. We don't see the febrile non-hemolytic transfusion reactions. UK blood, because it's packed cells, is predominantly in SAGM. We don't see TRALI with our patients, with our current blood supply. But clearly, if you were using whole blood, you would have a consideration and a risk of that.
Thank you. Now, there is a question for Professor Porter. Hi, Professor Porter.
Hello.
What is the meaning of a serum ferritin level of 1,500? And is it possible to reduce serum ferritin, high serum ferritin levels just with the ferriprone?
Okay, so we understand the relationship between ferritin and liver iron broadly. That is to say, statistically speaking, you can predict the liver iron from the ferritin. But in an individual patient, that isn't possible because of variability between patients. For example, if someone has a fatty liver, then that will put the ferritin up in a way which is not related to the iron. Also, in different disease processes, the relationship between liver iron and ferritin differs, so that in non-transfusion dependent thalassemia, there's a different relationship between ferritin and liver iron, and also to some extent in sickle cell disease as well. So there is a broad relationship. We use it. We use the trends more than we use the absolute levels, but you have to be careful about how you use it. Now, your other question was what levels of ferritin, how low can you go? I think with monotherapy, with deferriprone, for example. In general, I would say about 2/3 of patients who are regularly transfused at a moderate to high level need a second chelator to achieve good iron control of the liver. And that would be by adding desferrol traditionally. And that would traditionally be by giving desferrol as well in various ways. But nowadays, people are also using Exjade under those circumstances. So monotherapy is not, with deferriprone, is not a reliable way of controlling the liver iron as monotherapy in about 2/3 of patients with thalassemia major.
Thank you. There's another question for Professor Walker. A question for Professor Walker. For thalassemia patients with pulmonary hypertension, what is the ideal pre-transfusion hemoglobin level? And what about volume overload during transfusions of these patients with pulmonary hypertension? You have to unmute yourself, Professor Walker.
Thank you. Sorry, Dimitris. You dropped out with the first question. Could you just repeat the first part of the question? I got the second.
Okay. Yes. What is the ideal pre-transfusion hemoglobin level for a patient with pulmonary hypertension?
I think it's less a factor of ideal pre-transfusion levels, more maximizing the reduction in intravascular hemolysis, because that clearly is a factor both acutely and long term. So particularly in the sickle scenario, if we're seeing a trajectory of gradually increasing right heart pressures, I will pressurize Professor Porter and my colleagues in hematology to consider more transfusions for those patients to reduce intravascular hemolysis, and that can be a successful approach. I think Dr. Shah covered for us the fact that in the UK we get Paxel, and they would be more aware of this than I am, but volume overloading in the absence of severe right ventricular dysfunction isn't a major issue. If it is a particular issue in certain individuals, then I believe there is no contraindication to using loop diuretics such as furosemide to cover transfusions. But my colleagues will put me right if I'm wrong, but I don't believe that volume overload poses an issue for us.
Yes, great. Any other comment on this question?
Well, the only comment I would say is the difference between different diseases, which Malcolm Walker already alluded to. So in NTDTs, people who get into problems with pulmonary hypertension, you're probably going to modify your transfusion regime accordingly to try and minimize the exposure to the patient's own red cells, which are prothrombotic.
Thank you. And now there are some questions for Professor Terpos. First, what is the risk of infections by denosumab in thalassemia?
We have used denosumab a lot, not only in thalassemia, but outside of thalassemia in osteoporosis patients, but also in malignant diseases where the dose is, as you know, much higher, is 120 milligrams subcutaneous per month compared to the 60 milligram every 6 months in osteoporosis and thalassemia patients. We don't see any increase in infections. I know that there were some meta-analysis in osteoporosis patients where we have seen some infections, a slight increase in those who received denosumab, but it's something that we haven't seen in our patients, both in the thalassemia setting, but even outside of this setting.
Thank you. And what is the role of luspatercept for bone disease in thalassemia?
Okay, you may not know exactly the history of this drug that starts with another one, which is sotatercept, and we firstly checked it in patients with multiple myeloma, and we've seen that as a side effect, we had a great increase in hemoglobin, more than 20 or 21 grams per deciliter in patients who received chemotherapy, and that specific publication was MPT, methylprednisolone and thalidomide. And so we suggested the company to try it in patients with, first of all, in animal models, and if it is okay, to go for patients with thalassemia and myelodysplastic syndromes. And this is how the story began. And then after sotatercept, we had luspatercept. In that first publication, we've seen that sotatercept had a very good effect on bone metabolism in patients with myeloma. We know that there is a good effect also in the bone mineral density of patients with thalassemia. It is a sub-analysis of the main studies that is going to be reported soon. And luspatercept has not so strong effect on the bones like in the red blood cells, but also there is a rationale of increasing the bone mineral density. We need the data in order to be sure about that. But I think that regarding its biology, it may have a good effect on bone metabolism in thalassemia.
Thank you. And last question for you also. Are there any urgent treatment recommendations for osteoporosis in thalassemia?
I think that the major issue is that you need to prevent osteoporosis, or for the patients who have osteoporosis to do your best. We don't have yet the bone anabolic agents for other for thalassemia, for example. We need to know exactly if a bone anabolic agent like romosozumab, who has been licensed for osteoporosis, an anti-sclerostin antibody. We are trying to have it for studies in thalassemia and in malignant diseases also. Possibly the anabolic agents would be very good from the part of the bone, but we need to be very careful about the side effects. So we need to have a proper study for thalassemia. Otherwise, I think that both denosumab and zoledronic acid are very good drugs in the treatment of osteoporosis in thalassemia. Patients, don't forget that in thalassemia, we don't see the number of fractures that we see in patients with osteoporosis with similar T-score. So I think that with the proper management, our patients will not face dramatic problems because of osteoporosis.
Thank you, Professor Terpos. There is a comment by TIF Executive Director, Dr. Andrew Eleftheriou, on the need to introduce quality standards and calibrators for every intervention in patients with thalassemia. Otherwise, we are risking to endanger our patients and perhaps misinterpret the effectiveness of treatments. So any comment on this, Professor Porter, perhaps?
Thank you. I think some of this is going to be expanded upon later in the program, but we've had many discussions about quality control with MRI, and Malcolm Walker could probably comment more than myself. But what's come into focus recently is that we need to keep an eye on the actual drugs that people are receiving. If you go across the globe, there are a lot of generics now, and the quality of these have not been fully validated. So we have to be very careful, and maybe some work with TIF or by TIF on what people are actually getting would be helpful to patients.
Thank you very much.
Just to make a comment where I've just finished, in fact, it's just gone for publication, a study that we performed in India. And what is very clear, this is over 100 thalassemic patients studied on 2 occasions. What is very clear, many of those patients have investigations by non-validated centers. And I'm afraid to say that the results they receive can be very, very misleading. And in this context, misleading results can endanger more certainly the long-term outlook. So it is a really important issue. And the concern is that actually it's relatively simple to fix, but you know, there is a great need for standardization. As I said, Professor Porter mentioned this is going to be discussed, I think, on Monday.
Thank you all for the excellent session. We don't have any more time for discussion. I will now pass the floor to Professor Dusheko to close the session. Thank you.
Thank you very much to everyone. This was an excellent and informative session. We thank all the speakers for preparing their talks with great diligence, and I hope the audience enjoyed it. The comments were made in the question and answer session about good quality care and also integrating care. And from a hepatologist point of view, we didn't have a chance to address questions through Dr. Koskinas, but clearly several speakers have pointed out to the disproportionate morbidity being seen from liver disease as well in thalassemia. And I think what this calls for is effective treatment of the hepatitis viruses, perhaps lowering the thresholds at which we treat for hepatitis B because of the possible synergistic effects and the endemicity of hepatitis B worldwide. So I just wanted to point out to some of the morbidity and early age of presentation of hepatocellular carcinoma in in patients with thalassemia. We must address this. So the final comment before closing would be just to emphasize what has been suggested about good integrating care, making sure that we have patients with thalassemia under appropriate surveillance and referral patterns that make this seamless for patients so that we can at least diagnose tumor when it's occurring. And remember, this will occur with some latency in patients, even if they've been treated successfully for hepatitis C, so that we can improve the outlook from this dreadful disease. So it's time to close. I'm sorry we don't have more time. I'd like to thank my co-chairman. I'd like to thank Thalassemia International Federation, the speakers, and the audience for attending this morning. Thank you very much.
Thank you.
Thank you all. Thanks, Demetrius.
Thank you all.